Welcome everyone to today's MDA industry webinar. The title today is Hospital Proven Airway Clearance Therapy, OLE Therapy, now available in the home. My name is Dan Schmiel. I am the Senior Global Product Manager for the Volara system. Thanks everyone for being here today. I'm very excited that Dr. Lisa Wolfe is joining us today from Northwestern University, and Dr. Wolfe comes to us with a really unique set of experiences. Dr. Wolfe has extensive experience using OLE therapy inpatient and was instrumental in the pivotal or the feasibility study for OLE therapy in the home. And now with Volara, an exciting product from Hillrom, it's a product we've been working on for the last 5 years. This is now the ability for us to take OLE therapy into the home. So thanks to the MDA as well for making this this industry update possible. I'm going to take about 5 to 8 minutes and just provide you some background on kind of the succession of devices that Hillrom offers in OLE therapy, and some background on the therapy, the mechanism of action, and some indications for use. And then please, this is a learning event. I'm going to ask all of the viewers today, if you have any questions for Dr. Wolfe, please put those in the chat and we'll make sure we answer as many as we can. If we're not able to answer those, we'll follow up one-on-one afterwards. This webinar is videotaped, recorded, and will be archived for later viewing. Many of you may be familiar with the Menineb device, and you can see this is the predecessor to the Volara device. And Menineb delivers the same OLE, oscillation and lung expansion therapy that we deliver in the successor to Menineb and Volara. But really, you've got 3 therapies in one. You have the continuous positive expiratory pressure, the continuous high frequency oscillation, and then the aerosol mode. With Volara, you have a very different device, as you can see. This is an electromechanical device that's electronically controlled blower and manifold design. So unlike the Menineb system that uses wall oxygen, Volara is a self-contained device using a digital touchscreen for precise programming. And it has a very unique sensing technology, which, because the device is delivering driving pressure to the patient, we're able to actually sense that pressure continuously as it goes to the patient and give you those readouts live to the digital screen on what pressure you're delivering to the patient. And then it also gives us an opportunity for safety, increase the safety profile. An optional rechargeable battery makes this device completely portable. Now, the patient interface options for Volara are mouthpiece, face mask, a tracheostomy, and then also for patients on mechanical ventilation. So you have a number of different patient interfaces, and that helps to improve the versatility of the device. So just a little bit more about the mechanism of action. It's a very unique therapy, unique to Hillrom, this oscillation and lung expansion therapy. And the first cycle in the therapy is CPEP, continuous positive expiratory pressure. And here the device is the patient's breathing against the device, either between 5 and 25 centimeters of water pressure is delivered to the patient. And as the patient's breathing against this device, the pressure, the therapy is going all the way down into the distal airways. And that's really the key difference here with this device, is that we're delivering that therapy very distal into the patient's lungs. So this is going to open up the airways. And that's a 2.5 minute cycle. Which is followed by another 2.5 minute cycle of continuous high frequency oscillation, or CHFO. And here you've got chest physiotherapy that oscillates the airways with 3 different levels of frequency of oscillation. And this is going to give you that positive oscillatory pressure all the way down into the distal airways. It's going to help those secretions mobilize and move up into the upper airways. And the pressure that can be delivered in the home care setting is between 5 and 50 centimeters of water pressure in CHFO. But in the acute care environment, that CHFO can go up to 70. Simultaneous to both of these CPEP and CHFO cycles, the device is also going to nebulize your medication. So it's a very unique device. The intended use for Volara is, the mobilization of secretions, lung expansion therapy, and the treatment and prevention of atelectasis. So that's a new, having this intended use in the home is really, we're very excited about that. And then also has the ability to supplement oxygen when used on oxygen supply. So the patient population for Volara is adults and children over the age of 2 in the acute care setting, and in the home we're indicated down to age 5 for this device. Now in the inpatient environment where OLE therapy has been used for the last 7 years, you can see some of the different areas the device is used at the emergency department, ICU, both pediatric, medical, and cardiac, and then post-surgical units, and then on the general floor. And then now, of course, it's available in the home for that continuum of care. Some of the benefit patients that might benefit from OLE therapy are those patients that have those excessive secretions, retained secretions, mucus plugging, airway obstruction, chronic inflammation, and then those are risk factors are going to result in chronic infection, atelectasis, decreased lung function, recurrent exacerbations, and recurrent hospitalizations. So I'd like to just take a minute and introduce Dr. Lisa Wolfe, who is the professor of medicine, both pulmonary and critical care and neurology. So she brings a very unique education and professional skill set to this discussion at Northwestern University. So I'm going to ask Tori if you have any, or I'll look up in the chat to see if we have any questions. Nothing open. Please, anyone who's on the call today, please feel free to put your questions in the chat. Dr. Wolfe, one question we get frequently from clinicians that we call on from Hillrom is, when do you prescribe the OLE therapy for your patients at home? What are kind of some of the considerations that you have for that decision?
So thank you for inviting me and starting with this question. Can you guys hear me okay?
We got you.
Okay, great. So the first thing is, and I know our audience today, or I believe our audience today, is sort of a mixture of neurology and medicine and maybe some respiratory therapists as well. And I do think that the decision about airway clearance is something that you come at differently depending on sort of your background and which kinds of patients you're treating. So in our patients who are sort of classic pulmonary patients, we use OLE therapy for, say, those with chronic bronchitis, cystic fibrosis, COPD, that have very thick, tenacious secretions. And for those patients, the humidity and the vibration are of the most importance. And really the pressure is small and limited in its relevance. But when we talk about patients that have neuromuscular disease, those that have diaphragm weakness, chest wall weakness, their real difficulty is in cough, but also many of them have swallow impairment with chronic aspiration. And in that situation, the chronic aspiration, small particles, saliva, etc., need to be mixed with the therapy that will help them to cough the secretions up and out. The problem that we see is that in a lot of patients who have significant bulbar dysfunction as a part of their disease, the use of a mechanical inexsufflator or a mechanical cough assist device can be challenging because during the exhale component of the cough, you'll see that these folks get a lot of posterior pharyngeal collapse, which can be very challenging. Sometimes the answer to that is to use less pressure. Sometimes the answer to that is to put pressure during the position between inhale and exhale. But the beauty of the OLE therapy is that we can increase the pressure during the CPAP component to 15 to 20 centimeters of water pressure helping to facilitate cough as we're intermittently using the vibrations to moisten and loosen secretions so that they can get up and out as part of the cough process. And because we do it in a cyclical pattern where you're alternating between vibration, pressure, we're allowing the patient to get alleviation throughout the treatment period rather than just trying to give a therapy for 15 or 20 minutes and then just expectorating afterwards. So this is the kind of situation in which we can modify the settings on the OLE to really meet the patient's needs. Is that helping to answer the question?
Yeah, no, I think so too. That's definitely helpful. I'm just wondering, so can you talk a little bit more, Dr. Wolfe, about when you select OLE for a patient and when you select MIE for a patient and maybe when you select both?
Yeah. So MIE is going to be most effective in patients who have specific diaphragmatic dysfunction, but who have no issues with bulbar dysfunction and no issues with cognitive impairment. The reason that I say that is because in the setting of bulbar dysfunction, like we were talking about previously, you'll see a significant collapse of the posterior pharynx as a part of that process. The two most important papers that have shown that, one by Tina Anderson, who's a speech pathologist, and another by Jesus Gonzalez, who is a pulmonologist looking at patients with, ALS. And the reason that we get concerned about this data is that if you have a patient that's given MIE therapy and their complaint is that they can't tolerate it or that it doesn't work, it may be because they have this kind of bulbar dysfunction that's limiting their ability to really produce the maneuver necessary for the MIE. In addition, for patients that we have, say, who have ALS, but previous to having ALS had been significant smokers or had significant asthma, their issues in terms of chronic sputum production mean that the vibration and the need for humidity is significant. And so just using the MIE by itself may not be sufficient. And then the third class are those that have frontotemporal dementia, again, frequently noted in our patients with ALS. Although I understand we have some pediatricians here today. Is that right, Dan?
Yes.
Yeah. So for pediatricians, it's not so much an issue of frontotemporal dementia, but it is an issue with developmental delay. It's the same sort of challenge, which is that you have to have a really good understanding of how to interact with the cough assist machine so that you time it appropriately on both inhale and exhale. And in those with FTD or developmental delay, that might be a significant challenge, and it may not be appropriate for them to use MIE therapy. And it may be just easier for them to get benefit from OLE because there's less in the way of teaching and learning that's involved in the curve of getting good benefit from the device.
Yeah, thank you, Dr. Wolfe. You know, another question is the use of an MIE device, performing breath stacking with an MIE device. And now that you have OLE for home, how does that change, the frequency that you use breath stacking for your patients? Now that you have OLE, do you sometimes prescribe OLE for that?
What I would say is that lung volume recruitment as a maneuver can successfully be performed in a lot of ways. I will say, especially for patients with ALS, for whom the initiation of lung volume recruitment happens for at least in our office from the time of diagnosis. and yet they may not have any issues at that point with cough or alleviation of secretions. And so we'll use a resuscitation bag to do lung volume recruitment at that point. But further down the line, if the patient has significant issues with worsening weakness, worsening swallow, difficulty with alleviating secretions due to weak cough, you're going to clearly have to expand from just a resuscitation bag to something that has more pressure delivery. What we like about using the OLE at that time is that we can significantly increase that pressure to, say, 20 centimeters of water pressure, allowing you to do lung volume recruitment, but they're also simultaneously with that treatment going to get vibration and humidification. And so it helps to be more efficient in their therapy to get both lung volume recruitment and nebulization simultaneously. And so what I would say is that lung volume recruitment remains very important, but at different stages of the disease, different devices and different techniques are going to be appropriate ways of delivering that lung volume recruitment.
Yeah, it's interesting. So I'm just, the role of technology in caring for these patients is a question of, when do you get involved? What device do you use? I'm just curious, now that you have the OLE therapy for the home, are you, engaging technology into your patients' lives earlier now that you have OLE? I mean, has that changed?
No, because our goal is to develop a habit of doing good lung volume recruitment from the time of diagnosis. And if someone has a vital capacity of, say, 75 or 80%, I don't need an OLE at that point. Well, except those that have underlying severe bronchiectasis or bronchitis coming into it, right? So that's a different patient. But I think that the point is that at different points of disease, at different times along the curve, you're going to need more support from technology as the patient gets weaker. And so we don't do it from the moment that they start. And that's for a lot of reasons, not least of which is the fact that very early in disease, our patients want to have something like a resuscitation bag that's super light and easy to carry around and not very technology dependent. And it feels more like going to, the gym to exercise and less like a medical treatment. And as the course of disease goes forward, that changes. And as that changes, the devices that we use change. And so that's when we talk about using OLE.
Yeah. Yeah, so I'm just going to shift a little bit because we've been talking about the home, but I know you have extensive experience with OLE therapy inpatient.
Yeah.
And I wonder if you could just talk a little bit about, it's kind of an open question, but when you use it, why you use it, what are the benefits that you see inpatient? And even now in today's environment, if that's changed.
Yeah, so, oh my gosh, you asked the loaded questions, Dan. I'm telling you that. So first of all, we are in the middle of a study to look at the use of OLE therapy in patients with COVID. And obviously I can't say much because we're in the middle of still collecting data. What I will tell you is that the preliminary work that was done at the University of Minnesota looking at particle size showed that basically the heated humidification that we use as part of OLE therapy makes particles so heavy that we don't have to worry about AGP generation with OLE therapy in that setting. And Dan, I'm sure you have that data that you could probably share with anyone who's interested.
Yeah.
The next thing is, after showing that, was, how much do respiratory therapists accept being able to do OLE therapy on patients in the hospital? I think this is worth a discussion because, one of the other hats that I wear is as a medical director for respiratory therapy. And all of us, I think this is throughout the country, because I have not spoken with a colleague who doesn't have this problem right now, talking about the shortage of respiratory therapists. It's becoming more and more prominent as we have needed to expand our number of respiratory patients in hospital, and the fact that we just have fewer therapists available. And one of the things that we like about the OLE therapy is that it's faster for the therapist to do, so that they can be in and out, rather than, okay, first I'm going to give a neb, and by the time you set that up, clean that up, that's 15 minutes. And then I'm going to do an airway clearance maneuver, which might be manual chest PT in some places, might be a therapy vest in other places, might be a cough assist in other places. And that's going to take up another big chunk of time. So now you've got one therapist to do a neb and some airway clearance for one patient. It, at a minimum, is going to be a half an hour. Our therapists don't have the time to do a half an hour per treatment per patient. And what we have really found effective about OLE in the hospital setting is that it just makes our respiratory therapists more efficient, because they can do combination therapy. And the patients like it because they really feel the difference a lot faster when the treatment's delivered faster, and with the option of higher pressure settings, which we can get with the OLE. Dan, one other thing, if you don't mind me sort of putting in my 2 cents on this, is that, currently in our hospital, and I know in many hospitals, we're using the standard MetaNeb device, which is the one that you showed earlier on your film. And pressure settings on those are more challenging, because the therapist has to adjust based on the pressure gauge as it's being delivered. One of the changes that we're going to see going forward is that Volara therapy meant for the home will be used in hospital with a standard graphical user interface that will allow us to dial in pressures rather than have to sit there and watch a pressure gauge and put it in. I think from the perspective of a respiratory therapist and a physician writing orders, this is also going to make it a lot easier to use. Because right now, when I go in and tell my therapists, hey, deliver that MetaNeb at 15 of pressure, or 20 of pressure, or whatever it is, 5 of pressure, the therapist is like, oh, what does she want me to do? And I'm going to have to sit there and watch the dial. And so I do think that this is going to be even easier than it is right now as we go forward with the technology changes. The other thing that we've noticed is that in our patients that have really thick, tenacious secretions, especially those that have issues with mucus plugging, in a lot of institutions, really the only answer to that is bronchoscopy and or manual chest PT. And this is giving us an option that can help to do good airway clearance, and to do it in a way in which we can do it with respiratory therapy efficiently and hopefully avoid, multiple bronchoscopies. But what's happened in the past is you get to a place where you're like, oh, fabulous, I cleared up the airway, I don't have to worry about mucus plugs. And then the patient goes home and the whole thing happens all over again. And now we're able to get, for many of our patients, the Volara in the home so that we can continue therapy. I'm not going to sit here and say that it's easy to get for everyone, because there are insurance challenges, and there are often times that I have to write notes and do that kind of thing. But at least it's an option for us, where it didn't used to be in the past.
Yeah, thank you, Dr. Wolfe. That was a question that just came in, is what is needed for insurance payment as far as qualifications? Any kind of, you've done a lot of work in that area, Dr. Wolfe. Any kind of suggestions that you could share?
Yeah, so there's a couple of things. One is that in our patients that have bronchiectasis, we're seeing a slower uptick from insurance companies on coverage. We have had some better coverage with Medicaid than we have with Medicare. I don't know why. I'm in Chicago. Maybe it's an Illinois thing. I don't know. I will say that when we write our letters, it's important for us to stress that we can get 2 therapies in one by using this device, because for Medicare specifically, the way Medicare rules are written, you get 1 device. You don't get 2. Excuse me. And so if you can really explain to the insurance provider that this patient absolutely needs 2 modalities, and this is the only way that we can do it, we've had more success that way. And I think the other thing that's, I don't know, this is very strange. I'm not saying that any of this is logical. The Medicare specifically has been better for us if we can show that we've already tried a standard nebulizer and failed. Now, to me, it doesn't make a lot of sense in somebody that I know has neuromuscular disease and needs the additional pressure, both for lung volume recruitment and for cough, that I should start something that can't provide that and then step it up. But that's where we're at, and we have found that just doing that and getting it over with is helpful.
Yeah, no, that's I think that's going to be very helpful to the questioner. And at Hillrom, the Volara device, just so everyone's aware that's on the call or might be watching it in an archived fashion, is the miscellaneous code is being used to get approval for the Volara device, and that creates challenges, to be sure, but I will say from a Hillrom perspective, we've been very pleased with the percentage of commercial payers that are covering the device. And I think it's, yeah.
The only thing I would say about all of that, just having done this for 20 years, is that especially for the people that are archived, it changes about every 20 minutes what the appropriate code is and how lucky we are or whatever. And so, yeah, it's all great today, but I can't tell you what tomorrow's going to look like.
Yeah. Yep. Yep. Well, good. Well, Dr. Wolfe, I know you have a busy day, and for everyone on the phone and online, thank you for Dr. Wolfe for your time today, and thanks to the MDA. And as I mentioned, I know there's many people, I've been getting some texts here, Dr. Wolfe, that there's a number of healthcare teams that want to be on, but they're in clinic and they're just bombarded. So this is going to be archived. So thank you, Dr. Wolfe. Thank you, MDA. And thank you to anyone who's watching.
And also to the MDA, who we love, kisses. Listen, if there are MDA centers on this call who are struggling with airway clearance or have issues with airway clearance, please reach out to your MDA rep, because, they can always find me. We have an MDA rep in our MDA clinic who can, bring me questions or get us in touch. So thank you very much.